What we know since more than 1 decade is that 60% of our lower-risk MDS patients can respond to ESAs if they are selected according to the variable that we already know since a long time, that is level of endogenous EPO below 200 units liter, lower risk, possibly non-transfusion dependent, and without cytogenetic abnormalities. So these are the patients who will respond for sure, but the response cannot last forever. So the patient who fail, they lose response and their hemoglobin is declining progressively, sometimes really going back to transfusion dependence. This is something that we should avoid. Now, the alternative we have now are to switch to an experimental study or give Luspatercept in the patient who have MDS-RS, and in the US also in the patient who are who do not have ring sideroblast. When should we do it? Before I declare a patient a failure, I treat a patient at least for 3 to 4 months with optimal dose of ESAs, that is 30 or 40,000 units of ESAs per week. Sometimes we double the dose, sometimes obtaining a better response. But this has to last at least for 3 to 4 months before we can say that the patient is not responsive. So this is a primary resistance, and then we have the failure of treatment after a first response. These are the patients that are treated with the new agents I spoke about. So Luspatercept approved, and imetelstat hopefully in the near future if the drug will be approved. And otherwise, we have to go back to, unfortunately, transfusion and iron chelation together with it.